Our next section is called Atrial Pathology. In this section, we're going to talk about disorders of atrial voltage and several tachycardias that originate from the atrium. This is a commonly tested area on exams because patients can be highly symptomatic with atrial tachyarrhythmias, and also because the test questions can have clean question stems with AV node reentrant tachycardia or orthodromic reciprocating tachycardia and symptoms of palpitations, or patients can have atrial tachycardia that's associated with acute pulmonary diseases, thyroid disorders, etc. So here's the outline for this section. We will first go over atrial enlargement of the right and left atria. And this is important for risks of arrhythmias like atrial fibrillation and atrial flutter. We'll next go over premature atrial contractions, and then we'll talk about supraventricular tachycardia and the three most common diagnoses in this umbrella diagnosis. So AV nodal reentrant tachycardia, AV-NRT, AV reciprocating tachycardia in the orthodromic direction, AV-RT, and paroxysmal atrial tachycardia, or AT. We'll next go over irregular rhythms like multifocal atrial tachycardia and atrial fibrillation, and then we'll finish with the classic atrial arrhythmia, atrial flutter. Okay, so first is right atrial enlargement. This one is pretty easy to determine. You look at the P wave height in lead 2, and if the P wave height is greater than 2.5 little boxes, which is greater than 2.5 millivolts, then there is right atrial enlargement. Right atrial enlargement can be caused by atrial fibrillation with atrial remodeling. It can be caused by diseases that increase RA pressure, for example, pulmonary hypertension, tricuspid valve stenosis, or congenital diseases like Ebstein's anomaly. Our next ECG shows left atrial enlargement. This one's a little bit tougher to identify, but again, it starts with looking at P wave characteristics in lead 2 and V1. In a patient with left atrial enlargement, lead 2 will typically have a P wave duration of greater than 120 milliseconds, which is greater than 3 small boxes. Also in lead V1, the downward deflection of the P wave is greater than 40 milliseconds in length, and with greater than 1 millimeter negative deflection. That second part sounds a bit complicated, but if we think about the physiology, then it becomes more easily understood. Remember that the P wave begins in the right atrium, and the electrical signal then migrates over to the left atrium. If the left atrium is diseased, electrically slow, and boggy and large, then it will take much more time for the electrical current to traverse across it, thus delaying and stretching out the second part of the P wave, the part with the downward deflection. Second, if the left atrium is truly enlarged, the amplitude of the downward part of the P wave will be much greater. So in short, left atrial enlargement causes a pronounced and slowed downward deflection of the P wave in lead V1. The reason that we care about left atrial enlargement is that this is associated with atrial fibrillation, heart failure, mitral valve stenosis or regurgitation, hyperthyroidism, and hypertension. Now let's talk about some arrhythmias. Our first arrhythmia in this section is premature atrial contractions, or PACs for short. Sometimes, in addition to the normal sinus beat, there is an extra electrical signal in the atria that occurs earlier than expected, and that takes control of the heart rhythm temporarily. In this ECG, you can see that the fifth P wave comes early and causes the fifth QRS to also come early. If you look really closely, you can see that the shape of the P wave is also a little different than the P waves that preceded it. This is because an area of atrial tissue became electrically excitable and sent out an early electrical impulse that preempted the sinoatrial impulse for one beat. After this PAC, you can see that there's a short pause, a compensatory pause, before the normal sinoatrial impulse starts the next PQRST complex. We see another example of this on the 11th beat, where again we have an unexpectedly early P wave with a changed shape or morphology, followed by an early QRS. PACs are usually not life-threatening, but they can cause patients to complain of palpitations and brief episodes of dizziness or lightheadedness. Sometimes the burden of PACs can become really great. Here's an example of PACs in bigeminy, meaning that a PAC occurs every other beat. We see that the first QRS has one P wave morphology, and then the next tightly coupled P wave has a different morphology early and is coupled with an early QRS. Now let's look at tachycardias that have a sustained run of beats. This is an example of supraventricular tachycardia. This is really an umbrella term to describe a fast arrhythmia arising from the atria and that has a narrow or normal QRS duration. There are many arrhythmias that can fall under this category, but the three SVTs that we'll talk about today are AV nodal reentrant tachycardia, AV NRT. The second is AV reciprocating tachycardia, AVRT. And the third is paroxysmal atrial tachycardia, PAT. The first thing I want you to notice about this EKG is how fast and narrow the QRSs are. Since there is a QRS every 1.5 large boxes, the rate is approaching 200 beats per minute because 300 divided by 1.5 equals 200. Second, try to look for P waves here. It is really difficult to see the P waves in lead 2 and V1. And this may reflect the fact that in some SVTs, the P and QRS waves occur simultaneously, meaning that on the ECG, the waves are on top of each other. Here's our first SVT, AV nodal reentrant tachycardia, or AVNRT. AVNRT is actually the most common SVT, and it occurs in about 60% of cases of SVT. AVNRT happens in and around the AV node. Some people have an anatomical variant of the AV node, where there are both fast-conducting and slow-conducting pathways. In these patients, sometimes an extra beat or a conduction block will set off a reentrant circuit through the fast and slow pathways. In AVNRT, the ECG is notable for a narrow, rapid QRS with a rate of about 150 to 250 beats per minute. Because the AV node is in the center of the heart, it is sandwiched between the atria and the ventricles, and the AV node activates the atria and ventricles at about the same time. This means that on the ECG, the QRS and P waves are on top of each other, and given that the P wave is small, sometimes it can become buried within the QRS and is difficult to see. But sometimes you can see the P wave peeking out just behind the QRS, and you can see this best in lead V1. This is called a pseudo R prime because it almost looks like a secondary R wave. But this is not an R, rather it is a P wave buried in the QRS. Just for comparison, we see that when the patient converts to sinus rhythm, this pseudo R prime wave is gone because the P wave has now regained its rightful place before the QRS wave. This is really interesting, right? Our second most common supraventricular tachycardia is AV reciprocating tachycardia. In AVRT, our electrical signal goes down the AV node through the His-Purkinje system to the ventricles in the normal direction. This is called the orthodromic direction. The electrical current then passes from the ventricles to an abnormal muscular connection spanning the AV valves. This muscular connection is called an accessory pathway. From here, the electrical signal races back into the atria and takes control of the atrial rhythm before racing down the AV node for another cycle. When patients have orthodromic AVRT, they have palpitations and racing of the heart. This syndrome, from patients with symptoms of palpitations and AVRT, is called the Wolff-Parkinson-White syndrome. The QRS is narrow because the signal goes down the conduction system in the normal direction. It is possible for the electrical conduction to go in the opposite direction, i.e. down to the ventricles through the accessory pathway, and then backwards up through the atria, through the AV node. But this is usually an ugly, wide, rapid rhythm that's less common, and that's called antidromic reciprocating tachycardia. In both forms of AVRT, orthodromic and antidromic, you have reciprocating tachycardia. That means that the atria are activated, and then the ventricles, and then the atria in a reciprocating fashion. It's like an electrical game of catch back and forth. The only way to truly cure AVRT is to ablate or destroy the accessory pathway connection with a catheter or with surgery. Our third most common SVT is paroxysmal atrial tachycardia. It is paroxysmal because an area of the atrial tissue electrically wakes up, fires rapidly, and takes control of the heart rhythm, and this can happen randomly, or in bursts called paroxysms. Atrial tachycardia is often triggered by conditions that increase atrial inflammation, for example, infections, alcohol use, pulmonary disease, and can be found in patients who received heart surgery or who have congenital heart disease. On the ECG, you typically see a P wave in front of the QRS, although at faster rates. The AT actually might exceed the limit of the AV node, and then there can be dropped QRS waves. Take a look at the P wave morphology or shape on this ECG. Normally we would expect the P wave to be positive in lead 2, but we see here that the P wave is downward facing. We also see the same thing in leads 3 and AV foot. This means that the atrial wave is going away from the inferior leads and upwards towards the head. So the atria have an atrial tachycardia that originates from the floor of the atria instead of from the sinus node. Usually, we can either ablate the source of atrial tachycardia or we can give medications to suppress paroxysmal firing of the atria in this situation. Here's an example of PAT with a whole lot of extra beats. You can see here that this is definitely atrial tachycardia and not sinus rhythm because look at the P wave in leads 1 and V1. First, normally lead 1 has a positive P wave because the heart depolarizes towards the left shoulder. But in this example, the P wave is negative, suggesting that the P wave starts in the opposite direction. Second, look at the P wave in V1. It is completely upright. This means that because V1 lies over the right atrium, the wave is coming up towards the right atrium. Taking these two facts together, we have a P wave coming from the left atrium and that goes towards the right atrium. Thus, this is atrial tachycardia and not a sinus rhythm. Sometimes you have not just one area of the atria that fires, but several. This is common in people with pulmonary disease and also people with recent heart surgery. In this situation, we call this multifocal atrial tachycardia, or MAT. You can see that in this ECG there are multiple different P wave morphologies, and this tells us that many different areas of the atria are waking up and firing inappropriately. In other words, multifocal atrial tachycardia. Here's another ECG that you'll often see in sick patients that have compromised conduction across the AV node. In this first ECG, you can appreciate that you have a rapid rhythm with a narrow QRS. And I don't know about you, but I can't really see a good P wave here. The reason why we can't see a good P wave is that the electrical signal is coming from the cardiac crux, the middle of the heart, where the mitral and tricuspid valves meet the septum. Just inside and below this junction is where junctional tachycardia comes from, right in the center of the heart. The junction can wake up and fire autonomously when it's not receiving the appropriate signals from the atria above, or rarely can wake up on its own and just start firing randomly. Here's an example of the junctional tachycardia terminating. And in the yellow box, you can see how the normal sinus rhythm takes over, and now you see the normal P wave. Okay, so we're going to switch gears a bit and talk about a really important rhythm that you're likely to see on the medicine, pediatrics, surgery, and family medicine boards, atrial fibrillation. Atrial fibrillation is an electrical disorder of the atria in which there are rapid, chaotic firings of the atria, with a concentration of the signals usually coming from the pulmonary veins in the left atrium. Atrial fibrillation happens when several risk factors such as hypertension, heart failure, diabetes, obesity, obstructive sleep apnea, genetic causes, all converge to cause atrial remodeling. The remodeled atria have fibrosis and atrial enlargement and are more likely to fire randomly, leading to sustained atrial fibrillation. We care about atrial fibrillation for two main reasons. First, atrial fibrillation can cause atrial walls to become big, boggy, and slow, and inefficiently pump. Blood flow slows down in the atria, and then blood can pool and then clot. When the blood clot is kicked forward to the brain, this can cause an embolic stroke, and atrial fibrillation is one of the major causes of severe stroke. The second reason we care about AF is that uncontrolled AF can lead to heart failure, and prolonged AF can go from paroxysmal or episodic to permanent. Okay, so looking at the EKG, the two hallmarks of AF are an irregularly irregular rhythm and the lack of a discernible P wave. When I say irregularly irregular, what I mean is that the QRS waves are highly irregular, so much so that you cannot predict where the next QRS will fall. So in this highlighted section, by looking at the distance from the first to the second QRS, I cannot predict when the next QRS will come, and then the next QRS, and so on. Also, notice that there are no discernible P waves here. We see a lot of background atrial activity, but it's choppy and chaotic and unorganized. This example is so choppy that we call this coarse AF. Here's an example of AF that has a more fine atrial fibrillatory electrical activity. Notice how the baseline electrical activity is less choppy here. And as we mentioned, the QRS waves are highly irregular and the next wave cannot be predicted. This is classic atrial fibrillation. Sometimes AF can occur with rapid conduction from the atria to the ventricles. This is called atrial fibrillation with rapid ventricular response, or rapid ventricular conduction. We call this AFib with RVR for short. Notice how fast each QRS comes in succession. AFib with RVR is one of the main reasons people feel AF, because of the tachypalpitations that they feel and the lightheadedness and shortness of breath that they get from a reduced cardiac output of rapid, irregular heartbeats that don't give the heart an adequate time to fill. Let's take this example one step further and talk about the effects of rapid, irregular conduction to the ventricles. Remember that electrical conduction to the ventricles splits into right and left bundle branches. Sometimes the bundle branches, especially the right bundle branch, are stimulated at such a high rate that they're unable to reset fast enough to conduct the next heartbeat. But maybe the other branch, like the left bundle branch, still is able to reset fast enough to conduct the signal. In this case, we can have AFib with RVR that also causes a bundle branch block. In future sessions, we'll look at the details of bundle branch block, but I just wanted to give you a preview that fast irregular conduction in the atria can affect the quantity and quality of conduction in the ventricle as well. Sometimes it's difficult to see atrial fibrillation because of other things that are going on in the heart. In this example, the patient has a pacemaker that's pacing the right ventricle, so the QRS waves are regular and they're predictable. If you look really closely in lead V1 and V5, you can see small pacemaker spikes before every QRS wave. However, we notice that there are no discernible P waves before each QRS. It turns out that in this patient, their atrial rhythm is atrial fibrillation, but the pacemaker is taking control of the ventricular rhythm, which is now regular. So from this slide, it's important to remember that sometimes some chambers can have one rhythm, like the atria having atrial fibrillation, and other chambers can have another rhythm, like ventricular pacing. Remember earlier how we saw an example of the Wolff-Parkinson-White syndrome? If we remember back to the physiology, we remember that an accessory pathway is an abnormal muscular connection between the atria and the ventricles. And this piece of muscle doesn't act like the AV node because it essentially has no electrical speed limit. And so it can compete with the AV node for conduction from the atria to the ventricles and vice versa. Probably the time that this matters the most is when you have atrial fibrillation, because now the accessory pathway creates an electrical superhighway with no limits on electrical conduction. So all the fast irregular rhythms can migrate down to the ventricles and cause fast irregular ventricular conduction. This conduction is called pre-excited AF and is important because this could be potentially life-threatening. The treatment is to stop the atrial fibrillation, and when the patient is stabilized, go in and ablate the accessory pathway. In the green boxes, you can see how coarse atrial fibrillation is occurring. And in the yellow box, you can see how the electrical pre-excitation of the ventricle causes a QRS change. And so this is an example of pre-excited atrial fibrillation, where atrial fibrillation then comes down the accessory pathway and causes a wide QRS. Switching gears one more time, here's an example of atrial flutter. You can see that the low voltage atrial activity looks like a saw. And so these are usually called sawtooth waves. In this example, there are 4 atrial sawtooth flutter waves per each QRS, meaning that the flutter is going at a rate of about 300 beats per minute, and only one of every 4 of these is conducted through the AV node to the ventricle, where it makes a QRS wave. Also notice the shape of each sawtooth wave. In the inferior leads, 2, 3, and AV foot, notice how the sawtooth waves are pointing downward. In other words, the sharp angle is pointing down. Notice how in lead V1, the end portion of the wave is pointing upward. This signature means that this is typical atrial flutter. Typical atrial flutter is when the flutter wave traverses through an area of the right atrium called the cavo-tricuspid isthmus. In other words, the cavo-tricuspid isthmus is the area on the bottom of the right atrium between the inferior vena cava and the tricuspid valves. This is the typical area where atrial flutter goes through. Typical atrial flutter is said to move counterclockwise. This means that if you were looking from the patient's feet upwards towards the head, then the flutter wave would be spinning around the tricuspid valve in a counterclockwise direction. And in the boxes, here's an example of the inferior leads, 2, 3, and foot, with the downward sawtooth waves, and then the upward portion of the sawtooth wave in lead V1. For comparison, now look at this ECG. We can see that there are flutter waves about every 2 beats. So we have a 2-to-1 flutter pattern. Notice in leads 2, 3, and foot, the flutter wave is pointing upward. Also notice that it is pointing downward in lead V1. This is atypical atrial flutter, moving in the opposite direction, or clockwise, through the cavo-tricuspid isthmus. We call this atypical flutter. Also, note that flutter in the left atrium is called atypical and is rare, and usually occurs in patients with prior heart surgeries.